Hey, hi, this is Elliot Fishman, and I'm live, hopefully, on Facebook. And hello from work. Very quiet here. Um, you can tell I'm in my COVID-19 haircut phase. I'm kind of combing everything back, kind of has that really good, a good look. Kind of, as my grandson would say, kind of like Mufasa from The Lion King. Anyway, it's great to be here and hope everybody's doing well. And so today's topic, I chose something about contrast in CT, something we speak about all the time, and something that actually in the COVID era becomes also something you need to rethink. So I'll talk a little bit about contrast in general, and then I'll talk about some of the things that you might think about in the COVID era. So the question always is about contrast. Um, and again, we're going to talk about oral contrast, okay, not IV contrast. I think IV contrast we've spoken about before. Our perspective on IV contrast. We do lots of dual phase imaging. We always talk about the speed of injection being 4 to 5 cc's, 100 plus or minus 10 cc's of contrast typically. Omni 350, Visi 320, depending on the clinical scenarios. We talk about the importance of contrast delivery for vascular mapping. Vascular mapping be more than simply looking at the patient's aorta or dissection or coronary arteries, but looking at pancreas and pancreatic cancer staging, looking for liver tumors, renal tumors, splenic masses, kidney masses, and then not only looking for tumors, but then also being able to track etiology based on the patient's vascular map. So we talk about everything as vascular mapping, so it becomes super critical. So that's kind of easy. But then what about oral contrast? Now, if you look at oral contrast over time, over the past 40 years of CT, it used to be given on the floor. Patients had to wait at least 3 hours. You remember, those who've been around a while, rule out appendicitis at 2 a.m. in the morning. You would give oral contrast and say wait 5 hours because you don't want to come until 7 o'clock. The surgeons would always ask for oral contrast because they didn't want to come in 2 o'clock in the morning. They waited for the CT to be done. But then it became clear that some things like appendicitis is a good example. People that wrote articles. Some people gave rectal contrast. The people in Boston, they were a bunch of crazy people. We never did that. But some people found that whether you waited 3 hours or you waited 3 minutes, the accuracy for appendicitis was about the same. Now, in saying that, oral contrast is very valuable in many, many circumstances. The question then became, how long do you wait? What oral contrast do you give? We used to always give Hypake. Remember Hypake powder? A couple scoops in a gallon container, you mixed it up. We never were big on barium-based products. We never used them. The only time we ever used barium, we'd buy a box. We use it like once a year. If someone has severe allergy to contrast, you don't want to give them PO as well. And although oral, there's like 5 reported cases out of 1 billion cases probably at GE. But if you want to be super, super, super safe, you would give someone barium. I think we bought a box of 10 bariums a year. A box of 10, we used maybe 2 of them and they would expire before we used them. So that becomes important. And then we were always big on mixing contrast. 100 cc bottle of Omni 350 and a gallon of water will give you really nice density values of around 210, 220. Patients always liked oral Omnipake when we made it. We often flavored it, but there's been a number of articles that show that patients favor 3-to-1 oral Omni over a barium-based product because it was easy to drink, tasted better, it was cold, and it was just easy to drink. Barium-based products, if you ever tasted them or look at them, they're really thick, and if you're not feeling well, even drinking a vanilla milkshake would be difficult. Drinking a barium milkshake is no-go, and that's often the reason why people waited a long time. They would be drinking that barium contrast like they were drinking a cocktail at a party. With the oral Omni, just basically just tell people drink it as fast as you can. So that makes it a little bit easier, so the delay time is much less. We also then began using water as CT angiography became a more critical study. Water was something that we used. Now then something happened where a lot of the articles weren't really radiology related, but it was in like ER docs. There's Emergency Medicine Monthly I'm looking at. Contrast is unnecessary for most abdominal CTs. And basically, the quote from the article, the routine use of contrast, both oral and IV, and certainly rectal, is unnecessary for the majority of abdominal CTs in the ED. At least that's what the literature says over and over. Unfortunately, most radiologists disagree. What do they know? They haven't been using contrast since their residency, or at least since CT came along, and they feel more comfortable. Do they care that oral contrast will add 2 hours to the ED stay, or even when given, doesn't get to the cecum? Probably not. So, it's kind of this nebulous argument of people who don't read the studies telling you what to do. Now, I think one of the challenges of teleradiology these days is that people reading a lot of the Nighthawk stuff don't control how the protocols are done. So they're remote, they may be reading 100 hospitals in a 3,000-mile radius, but they're not telling the ER, the techs, give oral, give IV, give this. It typically is the ER doc who really doesn't want to be bothered and anything that is perceived to slow things down. Now these days, like oral Omnipaque, so I'll just let you know that if you think we're biased, we like it, but G does help support CTisus, so I'll do that disclaimer. But I think that one of the things with oral Omnipaque, and I argued about this since Dan Peters was in charge like 100 years ago. I spoke to Dan the other week. He's long ago retired from GE and Amersham and every place else. But what I always said is that pre-mixed bottles are better. And JACO likes pre-mixed single doses. Nurses like single doses. Nurses don't like mixing contrast. Some hospitals don't allow it. Some hospitals, the pharmacy has to do it, and then you have this massive delay. So single doses are really easy. In the COVID-19 era, CT single doses are better as well because people are very concerned about cleanliness and touching, who touched what. I mean, I would recommend that you give someone a wipe or something equivalent, and you give them the bottle of contrast, and don't even open it. Let them open it so no one's touched it. People are very scared these days, rightly so. So pre-mixed contrast really works really nicely. So then the question has been, what about oral contrast, neutral versus positive? So surely I think the simple things is, when do we use positive? If you can't give IV contrast, regardless of the app, you give positive contrast. You suspect a perforation, you need positive contrast. You're not going to see the perforation or the fistula or the tract without positive contrast. So anytime perforation or fistula, positive contrast. When you're concerned about an abscess, remember abscesses can be interloop abscesses, very easy to not be able to see them, especially in patients whose bowel is somewhat distended, and surely in a patient who's a post-op case. I have a number of cases where free air, pneumoperitoneum, you see the perfum duodenum because you can see the contrast pouring out. Remember, oral Omnipaque, for example, is inert when it goes to the peritoneal cavity. If I'm looking at something like GI bleeding, then we use water, right? Because you don't want any positive contrast in the way. If I'm looking at Crohn's disease and I need to see the enhancement of the bowel, I think then water is a good agent for distending things, and you don't want to use positive contrast material. Volumen we rarely use. Patients don't particularly like it, and it is fairly expensive. So I'll just stick with the positive and neutral. If you're doing, in terms of, one of the things we always worry about is gastric distension. Positive contrast is really good for gastric distension. You don't overread the presence or underread the presence of gastric pathology. Articles in terms of quality of studies, an article by Winkhofer in AJR last year that found that used 3 types of positive oral, and the bottom line was that they all worked, but iohexol had less issues with things breaking up and the like. So it was the preferred method. There was an article by McNamara that showed that 81% of patients preferred dilute iohexol compared to other agents. Now, I think a lot has been also written about, what about accuracy? I think accuracy, at the end of the day, when you do CT, the only thing that really matters is accuracy. And so there's several really good articles about accuracy. So this lecture is coming to you on May 28th, I think we are today, or something like that. There's an article in June AJR, which was published, the prelim was published a few months ago by Perry Pickard. And Perry wrote a very good article looking at the whys or why not of giving positive contrast, and basically simply looking at his experience. And what was clear from his experience is they went from positive contrast to water, and then they realized how many things they were missing. And so they've gone back to positive contrast, particularly in oncology patients, that if you don't use positive contrast, you're going to miss a lot of things, okay? And so that article is very well done, again, focusing on the oncology patient, where lesions are between bowel loops. Lesions can be easy to miss, okay? So that becomes very, very important as well to really understand. I'm looking at some of, and I'll post these, some of these are on CTisus, but I'm just trying to find, I want to give you the exact quote about some of the stuff that Perry put, but here's a quote. A disturbing recent trend, however, is the increasing decision to forego positive oral contrast material largely or solely for increased patient throughput, typically driven by non-radiologists such as emergency department physicians, surgeons, and even health system administrators. As radiologists, we need to ensure that such financially driven non-medical justifications are in the best interest of our patients. And so in his article, he spoke about indications: post-op bowel leak, suspected GI tract fistula, suspected interloop abscess, oncology staging or surveillance, non-specific abdominal pain, or other subacute symptom. His quote was, "I believe that there is definitely still a role for positive oral contrast in modern state-of-the-art abdominal CT. As radiologists, we owe it to our patients to drive the appropriate use of positive oral contrast material. At the very least, we should not allow non-radiologists to restrict its use solely on the basis of throughput concerns. Rather, we should allow considerations of image quality and diagnostic confidence to enter into the decision process." And we agree 100% with that. I think it's very important also how you use the positive contrast in terms of delivery. I don't think you necessarily need to wait 2 hours. We don't. You can wait 20, 30 minutes, then you get the stomach and duodenum, and often much further down the small bowel. Sometimes you don't, but you're getting a pretty good bang for your buck doing it that way. I think Perry's point, very rightly so, is you can miss a lot of things because patients with poor fat planes. People have written articles saying, well, above a BMI of 30, you don't need to give positive, you use water because there's a lot of fat, but sometimes fat patients don't have a lot of fat, so it's very difficult to make that decision just arbitrarily. There's another article I like, I think it's by Alec Megabo, and this is from a couple years ago. I think it's 2017, which sounds like a lifetime ago. I'm trying to find it, but Alex very much says the same thing. So he talked about not oncology, but the ER. Our emergency physicians do not see that oral contrast administration for CT hampers operational efficiency. In fact, they've expressed gratitude to our department for care and diagnosis. They have stated that delays in patient turnaround are more frequently related to overall demand on the scanner and not to the oral contrast consumption period. They are all acutely aware of the serious consequences of missed or incorrect diagnoses, either leading to inappropriate hospital admission or discharge, and will always choose good medical care over time slashing, corner cutting methods that impress the dashboard monitors, perhaps at the expense of excellence in patient care. And that's a typical Alec Megabo type quote. Impress the dashboard monitors. That means the pencil pushers, the administrators, perhaps at the expense of excellence in patient care. And Alex goes on to say, in summary, the radiology department at NYU has, through dialogue with the ER section, reaffirmed the benefits of oral contrast utilization for CT scanning in the ED. We found that stocking the oral contrast in the ED and allowing a 45-minute period for oral contrast administration coordinate with obtaining clinical and lab information, facilitate diagnosis with a high level of confidence and accuracy. As stated by J.R.D. Tata, it is an insistence on relentless attention to detail and insistence on the highest standards of quality and performance that are the keys to productivity and efficiency, most certainly not through cutting corners. And you can't say it better than that. And I think that's just a very good way of looking at it. I think you need to speak to your providers. I think the ER is the number one issue. And just tell them you're doing the best thing for the patient, you're increasing accuracy. And the key is not to have oral contrast somewhere that it takes 2 hours to get. It needs to be readily available. So whether it's in a Pyxis machine, whether it's in the ER by the techs, that you just give it to them right away. You don't wait till it get to you. Sometimes you have to, but by the time they go to a study and something gets done, the patient can drink it. It's rare that sort of a trauma case that the patient gets to you right away, and trauma you don't need the positive contrast. So again, you usually have the time. It's the lack of efficiency. And I think Alex's point is well taken and Perry's point's well taken. It's a matter of coming up with an efficient process. Now, I mentioned COVID for a second because many of you, and this is on the ACR bulletin, we're doing it ourselves, having the patients wait at the car because you don't want the waiting rooms to be crowded. The patient gets to your outpatient center, parks outside, close by, and then they just wait and then they come right in and get the IV. One thing people are doing, and it's a great idea, is take a bottle of contrast, give it to the patient when they're in the car, and let them drink it there. Again, they're sitting anyway waiting, so by the time they get called in, they'll drink it. Plus, the bottom line is sitting in the car doing nothing. You can't eat a croissant, you can't eat a muffin, you can't eat a bagel. You're not supposed to eat a bagel when you're getting a CT scan. Even if you had an S bagel or a whatever bagels you like in New York. But you can't be doing that, so give them something to drink, and you listen to the music, you put on your XM radio channel 6, 60s at 6, or 16, the coffee shop, whatever you're listening to, and you basically, life is easy, it's very, very efficient. And again, we talk about the cleanliness now, the safety now. So again, if people are really afraid and you want to really make people think you're doing a great job, which I know everyone is, you give them like a wipe or something, you get those, I know they're hard to get, but they're becoming more available. I had bought some before and I still have some. I'm in my office. I'm not advertising Clorox. These are like liquid gold, right? I hope no one comes and takes my box, but I have it hidden and there's like a rat trap, so if you go in to grab it, the thing bites you on your fingers, so you keep people away. Let's see if any questions anyone has. So let me say hi to John from Body CT and Alexandra from Poland. Hello. It must be evening time. And Lydiana in Palo Alto. What are the indications for positive contrast by ingestion? And I went through some of that stuff. And there are lectures on CTisus in more detail. We only have limited time here. But there are lectures on CTisus that are up there already. The protocol lecture really is good at looking at contrast, and I think I have another contrast lecture protocol that's coming up momentarily over the next month. So hopefully that'll be there. I want to say hi to Whitney. Nice office, excellent poster. That's my grandson Max's poster in the back there. Very valuable art, unpriceable, or priceless, maybe a better way of saying it. Say hello to Sue Deckelbell from Canada. I appreciate the hair. Yeah. I was often now, the person who cuts my hair for the last 30 years said they would cut my hair, but I'm thinking I'm going to see if I could do like, remember the Beatles when they had the long hair, John Lennon and George Harrison, they had really long hair? I'm seeing if I could be Sgt. Pepper. I'm not sure that it's going to last because it's going to get hot out, but I don't go out anyway. Oh, this thing about milk for contrast, forget it. People wrote articles about that. Milk, people, one article showed it was okay. First of all, if you have milk, it's going to spoil. Something else I don't want to worry about. Second of all, what are you going to do? You can order like the little milks, like when you were a kid, those little containers of milk, but you don't want to order like a quart of milk or a gallon of milk or something, or half gallon, whatever the milk things come in. And then you got to say, do you want 2% milk? Do you want 1% milk? Do you want regular milk? Do you want coconut milk, almond milk? I just think it's a bad idea. Also, I don't want a full stomach with milk. Give me someone IV contrast, because milk, for some people, gives them a little bit of GI distress, and the next thing you know, you have someone vomiting. You don't want to do that. So I think we'll pass for milk. The question is probably from somebody who lives in Pennsylvania or Wisconsin, where they have a lot of milk. Right, milk has gone up in price with right now, because not that there's not enough cows. There's plenty of cows, I'm told, and there's plenty of milk. But and this is not joking. It's like meat and milk both have had the issues with distribution because of COVID. So I know they had the problem with pork. I don't eat pork, but with slaughtering, euthanizing pigs because they couldn't get them to market because just the connectivity, and some of the slaughterhouses had issues with COVID. So I think that's being worked on. I know we keep kosher, and for us too, even now it's very hard to get kosher meat. A lot of the distribution, there's plenty of cows. I mean, the place I get meat from is upstate New York. That's all they have is a bunch of cows there. There's grass and cows. That's it. There's nothing else. So they got plenty of cows, but you got to catch the cow, then someone has to slaughter it ritually. You got to pack it, you got to ship it, you got to send it. Catching a cow is not that hard, but I think one of the challenges, has, all joking aside, has been this the supply chain, and I think it's getting better now. I think probably most of you who've been to the supermarkets know that for a while it was hard to get most anything, that everything was in short supply, whether it was Chips Ahoy cookies or a turkey or chicken or beef or pork or any other thing you might eat. And those things are getting better as well. So, and John Biacchino says milk vomit is the worst. Yeah, and you know that because if you ever had a child and the child vomits after they have milk, it's like, whoa, something you don't want to get into. Anyway, so hopefully that helps you a little bit. I think, doing the right thing is always the right thing to do. In my a talk I gave about contrast, it's coming online, I used this last quote from Aldous Huxley, so just showing how sophisticated I am. I quote like Eric Clapton or something like that, or George Harrison, all things must pass. That's my quote for today. But this Aldous Huxley, facts do not cease to exist because they are ignored. And I think positive contrast has a major value, and as Alec Megabos said, we need to do what's right for our patients. So with that, I'll stop there. I'll thank everybody for their attention, and we'll see you next week. Have a great day. Bye.